Hi, Fabi. How are you?
Hi, I am a little bit tired. And you?
Tired too, but we have to go ahead. I think I got sick.
Oh no.
Yes, I got a flu. My babies got a flu, and I think I'm going in the same way.
Oh, that's bad. Did you see any doctor?
Not at this moment. It's not. There's no complications
Oh, okay,
to worry about until this moment.
that's okay.
Yes, just well, my kids are with fever, but it's something normal in this situation, I think. Nothing to worry at this moment.
Yes, that's true.
Yes. So these days it's been so rainy and cold. I think that's
Yeah.
the problem.
Doctor, before my uh, classmates entered to the meeting, the Wednesdays, could I be on the class but without speak? In
Okay.
the Thursdays, can I be the last one?
Okay,
As
there's
I
no problem.
mentioned before, I get a job for vacations and I end like at 10 p.m.
Okay, no, there's no problem. But the schedule is changing with your classmates. I mean, in the order that not all of them are coming to the workshops. So
Okay.
depending on which ones come or doesn't come, at the end, the time could vary.
Mm-hmm.
But there's no problem for me if you want to be the last one. That's okay.
Okay, thank you very much.
So I'm gonna change this schedule and I'm gonna show it to the group. Okay.
Okay, thank you.
Okay, don't worry. Well, nobody's coming at this moment. What can we do?
We can wait just for a moment till they enter.
Yes, until 5 minutes, until 8 and 5, because
Okay.
it's important for us to start. Hi, Belkin. And Johan, thanks for coming on time. Please give me a minute, please. Hi, everybody. Well, let's wait 1 minute more and then we start, okay? Because, well, I think we all have a schedule to follow. Let me share the screen. Can you watch my screen?
Yes.
Thank you so much, Belking. Today, we have an interesting presentation, I think. So, Yes, it's time. So let's go ahead. Well, we are in our 14th class. 2 more theoretical classes and then we finish all the course. So let's use this time in order to finish all the material we have planned, okay? In that way, let's start with the presentation. Today we are going to talk about the history, the medical history, taking data, specifically, well, so many topics. But, well, of course, we all know how to do it. We all been practicing during the medical school, during job, and we know how to take information. That's why it's gonna be an interesting class, I think, because there are many topics to remember and to practice. First of all, we have to consider a full case history has all of these topics to consider while taking data, okay? We must take personal details, the patient presents the complaint. We ask for about the past medical history, the PMH, the drug history, family history, social and personal history. Of course, the patient has ideas, concerns, and expectations about the situation and all the things we are going to do. And we work about systems, we make a review, and we know how to ask about it, taking in account the complaints, of course. We have, well, lots of jokes just for having fun that are according to the case, okay? So, about personal details, well, we have to consider that sometimes it could be like little intrusive, and not all of the patients like to talk about it. But it's not our business if they like to talk or not to talk about it. It's our job to ask everything that we consider necessary to do. So we don't have to be shy about it. Just do all the things you need. Ask all the questions you consider necessary. And if there are more, just do your best and that's enough. In that way, Belkin, can you read this slide, please?
Of course.
Thank you.
Normally, patient personal details have been entered in their record by a nurse or administrative staff before a doctor sees them. However, and later consultation, a doctor may wish to check details such as address, date of birth, occupation, or marital status.
Okay, thank you so much. So you can see, you're in the staff, the administrations, maybe a nurse, maybe during the triage. It depends on the organization we work and how it's developed in our clinical center, hospital, everywhere we practice, we work, okay? Questions that we usually make, and we have to consider, and it's for us an obligation to make as well. It's about occupation, for example. Key questions: do you work, or maybe what do you do for a living? Directly questions, non giving too much ways to be out of the situation, to avoid the answer. And usually patients may respond, no, I'm unemployed, or I'm out of work. No, I'm retired, or I am a pensioner. Or maybe they say, yes, I work for a bank, for example, or I work in a factory, for example. So in that way, these keywords, we have to remember how to use, okay? These key questions are very important for us. Another question that is very important is marital status, of course. And we use the key question, do you have a partner? And the possible answers, no, I am single, no, I'm separated, or no, I'm divorced. Or maybe, no, I'm a widow, no, I'm a widower, no, I'm divorced, okay? Maybe they say, yes, I'm married, and that's all. Or another way, I live with my partner, my spouse, my husband, my wife. Or could be a sad answer, my spouse passed away last year. So we have to consider that ways of answering and the ways that the patient is explaining us the marital status, the marital situation, that is very important. So in that way, we know and we must remember that spouse can be a wife or a husband. Usually in England, we use this word, not in the USA, but there are many places that it could be a possibility to get an answer. So spouse, wife and husband, and that's all. Widow is a woman whose husband is no longer living. Widower is a man. So we get this difference, okay? To avoid saying that someone is dead, patients may say that person has passed away. So this expression is very common everywhere. I had patients that used to do it, to talk it, and if we are not sure about the meaning, we can make a mistake. So we have to consider that this expression is a common one. One of the most usual causes of consultation, of going to the doctor, we were saying in last classes, that was pain. So talking about pain, we have to consider the way of taking notes, just as an example, because everyone has their own way to do it, okay? In the case notes, well, they are kept for each consultation in the clinical history. The presenting complaint section of case notes records the patient's symptoms. For example, with these pictures, right-sided temporal headache, severe throbbing, lasts 24 to 48 hours. In this case, the patient complains of a headache. This is a huge resume that we were practicing during the case report. Do you remember how to do it? I'm sure you know how to work with this, and well, it's gonna be a piece of cake to write down. Now we have to consider the definition of pain, what the specialist, our experts say about it, the IAS and the pain group. Maybe, well, Fabiola, can you read this slide, please?
Yes.
Thank you.
Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage.
Okay.
Pain, updating the definition of pain. Pain is a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components.
Thank you so much. So those two groups are the most important ones in the study and treatment of pain around the world. So we have to consider the definition in order to get the correct idea what the patient is talking about. That's why I decided to use this. And then we have information that it's actual, and the definition is correct at this moment, okay? About symptoms, well, we were saying pain one of the most commonest symptoms. For headaches, for example, a doctor would expect to establish most of the features below. I mean, similar questions can be used for other forms of pain, not just for headache. And we have this list that is very important, okay? We have to consider the main site, radiation, character, precipitation factors, time of onset, time of resolution, frequency, aggravating factors, relieving factors, associating features, duration, severity. All we know these kind of questions because we make them all the time during our jobs, right? So in that way, just is to remember to practice with them and then use it in the correct way, in that order. I don't know, any volunteer for reading?
Can I?
Yes, go ahead, please. Belkin.
Okay. Future, typical question. Main site, where does it hurt? Show me where it hurts. Radiation, does it go anywhere else? Character, can you describe the pain? Precipitating factors, does anything bring them on? Time of onset, when do they start? Time of resolution, when do they stop? Frequency, how often do you get them? Aggravating factors, does anything make them worse? Is there anything else that affects them? Relieving factors, does anything make them better? Associated features, do you feel anything else wrong when it's there? Have you any other problems related to the pain? Duration, how long do they last? Severity, how bad is it?
Perfect. Thank you so much, Belkin. So in that way, we understand how to ask. So as I was telling you, we all know how to do it because we make it every day, all the time. In that way, we have the pain rating scale. It's just one way of asking about pain, of understanding what the patient is trying to transmit, the idea how he feels, and how he's evaluating and interpreting the severity of the situation, of the complaint. We have the description here about the minor pain, moderate pain, and severe pain. So in that way, with the numbers and with the chart, we ask for the patient to choose a picture, and then we can learn, we can understand how he really feels, because not always it is possible to do. On the other hand, it's not the only way to ask for about pain. This is just one chart, one scale, but we have all of these ones. For example, the OPQRST is for pre-hospitalized attention. Okay, all of these assessment tools are out of the hospital possible to make. All of these situations, we can use it. I left here the link, the website for checking these scales, these tools, because it's important for us to get the one that we can work better. And then, of course, learning how to use these scales and tools, we can make a correct evaluation of our patients. This is in general for children, for adults. There is no trouble on this. We also have specifically adult scales just for adults, for not making mistakes. And all of them are important to read, to understand, but just as information. It's not going to take into the evaluation. Don't get upset about it. Okay, this is just for information pictures and slides. for through the life. I mean, it's important. And we have these ones for pediatric patients. It's important because, of course, in the way they don't talk, they don't explain how they exactly feel. So we cannot avoid the information they give us, and we cannot give as a fact that all of the situation that parents, maybe the mother or the nursing in charge is telling us is real. So we have to get the correct tools, the correct ideas to evaluate a kid, a baby, a newborn. I don't know, it's different. It's not easy to evaluate a baby in pain because they have another way of answering, of course. But what say about this, the experts taking in count, I mean, all of these tools, these scales, of course, are prepared while we are prepared to interpret it. I mean, if I'm a practitioner during the pre-hospitalier and emergency room, I'm not ready for using these scales. Can you consider that my evaluation is the correct one? According to this article, around 6 to 7 from 10 practitioners make mistakes choosing which scale using is the correct one. I mean, which scale is the best according to the case they are talking about. So it's not easy to choose the correct one in the correct moment because it's a stressing situation to have a patient in pain. And of course, you are not going to sit and check and review which one is the best. So it's just with practice the way we can work and we can get the correct way of doing it. So this article shows us that sometimes you can make the mistake about the correct scale, and not always we get the correct evaluation. In that order, we can miss data or maybe overtake data. In the way we take more information, we over consider the situation. We not make a mistake during the treatment, but we lose time, and it's not the objective. Another part that is very important is the description of pain, and we have this list again. This list is showing us the characteristic of pain, how the patient get the description, and the explanation of that word. Okay, Johan, can you listen to me? Johan, or maybe John Harold?
Yes, teacher.
Okay, thank you. Can you read the slide, please, John Harold?
Yes. Patient description of pain and explanation. Aching and ache, a general pain often in muscles and joints, boring, like a drill, burning with heat, colicky, and intermittent pain which varies in intensity, comes and goes in waves, crampy or cramp, an involuntary spasmodic muscle contraction, crushing, a feeling of pressure, dull, a background pain, opposite of sharp, gnawing, biting, gripping, a feeling of tightness, scalding, like boiling water, sharp, acute, stabbing, like a knife, stinging, sharp, burning, like an insect sting, and throbbing with a pulse of or beat.
Thank you so much, John Harold. So you can see these characteristics, and our patients, of course, use this description. We know about it because, well, we are doctors, we know, and of course, you know the meaning. Those ones are the most common, and this list is going to be into the test, just for giving you the idea. And of course, we have more tips about describing pain. So these terms used to describe pain, this is the most important because the type of pain experience changes. Sometimes patients can confuse how they really feel the situation and can mix their description. So we have to get on the situation and practice and ask and ask and ask. And sometimes we have to explain the patient this meaning and then get the correct description of the pain in order to get, the diagnosis. In this list, we have more adjectives for describing pain, just for information, but it's important for us to know it, okay? It's important for us to recognize, to practice, and then to, in our free time, get the explanation, okay? This chart is the one that is going to go to the test. This one, no. I left this guy, this friendly guy, in order to understand that it's important. So we have to get another difference that is important, the acute pain versus the chronic pain. Catherine, can you listen to me? Are you there?
Yes, teacher.
Thank you, Catherine. Can you read this slide, please?
Okay. The difference between acute pain comes on suddenly.
Yes, suddenly.
Usually the result of injury, surgery of some time, similar, plus 6 months or less, relief when cause is treated. Chronic pain comes on gradually, usually the result of conditions that are difficult to treat or diagnose.
Perfect.
Last more than 6 months, difficult to find lasting relief.
Thank you so much, Catherine. So we see the difference between acute and chronic. With this joke, we can consider so many patients that can come to us. Well, they use the wheel of pain, and sometimes they decide that everything is hurting, that everything is in pain, and it's not easy to treat with them. Just a joke.
I am that person.
Yeah, don't worry, it usually happens. We have to get the difference in order the way of working with it. And according to the definition that we were reading slides ago, we can consider that pain is not just that situation, that physical situation. We have more ways to get explanation about how pains could be felt for the patient. That's important for us to understand when a vulnerable patient come to us and told me that I feel pain. There is too much to talk about, and well, we have to consider this. Well, going ahead, now we have to talk about the drug history, very important situation for us, for our patients. And of course, in this extract, we have lots of vocabulary to check and to practice. Maybe, Agar, can you listen to me?
Yes, teacher.
Hi, dear. Can you read this slide, please?
Okay. Drug history. It's essential to obtain full details of all the drugs and medication taken by the patient. Not infrequently, a patient forget to mention or forget the name of drugs they take. Some might be over-the-counter remedies unknown to the general practitioner. The significance of others, such as herbal remedies or laxatives,
Laxatives.
laxatives might not be appreciated but the patient. If it's no, it is necessary to determine the precise identity of the drug, the dose used, the frequency of the administration, and the patient's compliance or lack of it. It's important to ask about known drug allergies or suspect drug reactions, and to record the information on the front of the notes to be obvious to any doctor seeing the patient. Failure, no, failure, I don't, failure to
That's okay.
ask, failure to ask the question or to record the answer properly might be lethal.
Thank you so much. So here we have some expressions that we have important information about the importance, the drugs, the taking drugs, the over-the-counter remedies. Over-the-counter remedies are the ones that are free. Everybody can buy it without prescription. So it's important to get it in count, okay? In that way, let's check. Let's go ahead. Well, to find about drug history, usually we ask details of drugs and medications that, of course, as Agar was reading, are important to get. Are you taking any medication at the moment? It doesn't matter the situation, of course. It's not because there's a pathological situation. So maybe I consider necessarily to take something and I do it without any necessity, okay? Which tablet do you take? Our patients usually say, that's black or that white one that it's small and rounded. And you say, what? Which one? Yeah. So it usually happens. Or maybe do you use any over-the-counter remedies or herbal or homeopathic medicines? Usually patients tell us the truth about the situation. So I don't think there is too much situation. These questions are important not to forget about it, okay? About the frequency of administration, how many times a day? Maybe one, twice, I don't know, quit. It depends on the situation, right? Or about the compliance. Do you always remember to take it? We have patients, for example, diabetic patients that forget their oral antidiabetic drugs. And they consider that, okay, I forgot in the morning my pill. Now let's take 2 pills. And of course, it's not in that way. That mistake usually sends the patients to the emergency room with complications about the treatment. So we have to consider this. About side effects and allergies, of course, it's a very important fact to ask and then write down patient denies allergies that we know at this moment, because we all know when we take pills, it's an artificial element. And being artificial, anytime you can develop an allergy or a side effect that could be a potentially harmful to you, right? Do you get any side effects? Have you ever lived with that? Have you ever noticed that? And then you could get an answer. Or maybe, do you know if you are allergic to any drug? Sometimes our patients know about it and they can tell us that, yes, I know I have allergy to penicillin, for example, or no, I don't remember the name of the pill, but I know that it's an antibiotic, so what? If they said to us that, yes, I know I have an allergy, we must ask the symptoms they get in that moment. We must ask if they know how to treat it, or we must ask how many time passed from they take the pill until the moment they developed the side effect or the allergy reaction. I had a patient who was allergic to diclofenac, for example, that common painkiller, and she usually forget about this situation. And once she called my hospital and told us I need help because I took a painkiller. I'm not sure the name of the tablet because it was open. And now all my body is itching and with hot, I have a burning sensation. When we went to her home, she was red. The red syndrome is very common when you are allergic to diclofenac. So it's important to get it. And of course, patients, we have responsible ones and non-responsible ones. So get that idea, okay? Going ahead, we have to consider the family history. We have to note the age, the health or cause of death of parents, siblings, spouse, and children. We have to consider all the family members, okay? To find about family history, doctors usually ask. Maybe John Harold, can you listen to me now? John Harold or Johan?
Yes, teacher.
Yes, can you read this slide, please?
To find out about family history, doctors ask, do you have any brothers and sisters? How was he when he died? Do you have any children? Do you know the cause of death? What did he die of? Are all of your close relatives alive? Are your parents alive and well? Does anyone in your family have a serious illness? Is anyone taking regular medication?
Thank you so much. So let's consider this question. Do you know the cause of death or what he died of? These both questions are very common, and well, it's the way of expression we decide to use. Sometimes you ask your patients about, I don't know, your parents have any chronic illness, chronic disease, maybe a chronic situation, and they said no. Yes, okay. Anybody's taking regular medication? Yes, my mother takes. And you said, oh my God, okay, let's go again. Let's take the note again. So consider that these questions are important as for taking as much information as we can. About the social and personal history, we consider the relevant information about occupation, housing, personal habits, specifically recreation, physical exercise, alcohol, and tobacco. And in the case of children, we talk about school and family relationships. Why school? Because of course, it's an important place for getting in touch with the rest of the people, with practicing and working with well, how to be in the society. Sometimes we have situations where kids don't go to school, but they have other activities to recover that kind of contact. Sometimes parents decide to practice the homeschool. And well, in homeschool, of course, you have no friends from school, but in your free time, you make sports, you play a musical instrument, you go to arts. It's different. And family relationships, it's obvious why relationships are the base on how a kid is going ahead and how it develops, right? Ariana, can you listen to me?
Yes, I'm here.
Yes, perfect. Can you read this slide, please?
Okay. Typical questions in taking a social and personal history are: what kind of house do you live in? Do you live alone? Who shares your home with you? How old are your children? Are any of them at nursery or school? What's your occupation? And do you have any problems at work?
Thank you so much. We have more questions. Can you go ahead, Ariana, please?
Okay. Do you have any financial problems? Do you have any hobbies or interests? What about exercise? Do you smoke? How many a day? Have you tried giving up? What about alcohol? Wine, beer, or spirits? Can you give up alcohol when you want? How much do you drink in a week? What's the most you would drink in a week? Are you aware of any difference in your alcohol consumption over the past 5 years?
Okay, thank you so much. So I have an important expression, wine, beer, or spirits. Spirits is referring to drugs, to that kind of combination with drugs and alcohol, of course, that give you a very big sensation in that activities. But spirit is the way to resume it without being offensive to the patient. So it's important for us to remember that the way we are asking for not getting our patients in a bad moment. And well, these questions are important, I mean. And well, about the alcohol, about avoiding smoking and drinking, of course, it's not easy. Giving up the situation is not the best activity to treat at home, and it's not the best activity to treat with a patient. It's not easy to understand and to advise about it, but it's our job to go ahead with this. It's our job to explain the patient the sensations, the feelings, the anxiety they are going to feel, and we have to consider that we can go one day every day, and we have to enforce that idea to the patient, okay? Going ahead. About reviewing the systems, maybe Agar, can you listen to me?
Yes,
Yes, can you read this slide, please?
reviewing the systems. Once you know the main reason why the patient wants medical attention, it's sensible to ask about the system to determine the patient's general state of health and to check for any additional problems. The patient should be encouraged to describe symptoms spontaneously. Any initial questions should be open-ended as general as possible. Follow up with more specific question is needed, but avoid putting words in the patient's mouth.
Thank you so much, Agar. So you see, talking about, well, about complaints with patients, we have to get the encouragement to describe the situation without any trouble, without feeling upset, without preoccupation, using the open-ended questions and as general as possible in order the patient express. Sometimes we don't have enough time to do it, but well, we have to find the solution about this and try to use our time in the best way. In social services here in Bolivia, for example, almost all of them have a rule that is dictated by laws. We have 15 minutes per patient. Of course, 15 minutes are not enough, but we have to make magic in order to work with this time and then go ahead and get enough information to complete the correct diagnosis and let the patient talk and talk and talk, okay? What we referred about open-ended questions and closed question, of course, open-ended questions. For example, what's your appetite like? It's difference about a closed question. Have you eaten today? Well, having this today, I'm just asking for today. But about this other question, what's your appetite like? Of course, I'm asking for a period of time when the patient can tell me, okay, 2 months ago, I was eating more than at this moment, but but from 2 days ago, I don't want to taste anything, for example. If I ask just, have you eaten today? The patient might tell me, no, I didn't, and I have not eaten, and that's all. So it's not correct at the beginning, okay? Another open-ended question as example, how is your vision? Very general. If someone asks me how's my vision, I said it's terrible because without my glasses, I see anything. I'm almost blind, so I'm sorry. So it's not easy. How is your vision? Of course, very common question. And then we can work with this. I'm sorry, I got sick. Thank you. It's different if I ask, is your vision ever blurry? Of course, I can say no. And that's all. Closed question. I'm not going to direct the anamnesis in that way. Okay, going ahead. When we ask for systems, we make the review about how making questions of this. I'm sorry. We look for one of the most important systems to talk about. And of course, one of them is the central nervous system. Fabiola, can you listen to me? Fabi. Oops.
Can you hear me?
Yes, can you read this slide, please?
Okay, asking about central nervous system. 1, do you suffer from headaches? 2, have you ever had a blackout? 3, what about fits? 4, have you had any dizziness? 5, do you get a ringing in the cars? 6, have you ever experienced any numbness or tingling in your hands or feet? And 7, do you have any problems sleeping?
Thank you so much, Fabi. So we were practicing about symptoms, about signs, of course, and we know the meanings of this. And it's important because sometimes when we start with a simple question like this ones, as an example, we can get more information and get the correct way of directing our diagnosis, right? For example, have you ever had a blackout? Sometimes we don't ask about it because we don't consider it necessarily, but it could be interesting to start doing it. And then maybe we get more details about the situation that at this moment is being a problem, or about problems during sleep, the sleeping problems, sleeping troubles, maybe sleeping disturbances. And then we can consider more situations to treat and to work on with the patient. Of course, we are talking just about the central nervous system, but we have more systems to consider: the cardiovascular one, the urinary one. We know how to make the anamnesis, of course. About the patient ideas, concerns, and expectations, it's important to understand how the patient feels in order to get the attention, to be that bunny object of practice for a stranger one. And then, of course, the patient has doubts that maybe doesn't want to make because he feels it's not important, but we have to break that iced relationship, and we have to talk with the patient in a trustable way, in a friendship way, and get enough, I don't know, enough patience to listen that kind of situations. Catherine, can you read this slide, please?
Yes, teacher.
You.
Patient ideas, concern, and expectation.
Yes.
It is important during the consultation to give patient the chance to express their own ideas and concern about their problems and to determine what the expectations are. The letters ICE ideas, concern, and expectation are a way of remembering this.
Okay, thank you so much. So you see, the ideas the patient has sometimes is not the correct one about the situation he's suffering. For example, he might think that the situation could be worse than really is. Typical questions that we can use for get this information, for example, well, that we have to make is about ideas. What do you know about this problem, about this condition, or about this illness? Do you have any ideas about this? How do you think you got this problem? What do you mean by? And then get the patient explain us. And if there's a mistake, of course, we have to get in patience and correct it. Correct, be clear, be kindly, without being offensive, just for understanding that the patient could be afraid, could again vulnerable with that situation, because it's not easy to say sometimes how we feel. About concerns, we as a doctors can ask, what are your worries about this? And they are going to tell us the situation. Do you have any concerns? How might this affect the rest of your family? So it's important to the patient explains, because it's not an only one. He has family, the patient has a complete real and social situation that is going to change depending on the diagnosis, right? And expectations. We ask, what do you think will happen? What do you expect from me? What were you hoping we could do for you? We have to know, we must know what the patient is expecting for us as a doctors, what the patient really wants about it. So we have to consider all of these ways of asking in a very important way, with the importance, I mean, they really have for not losing information while doing the medical history. Oh, we also have to consider this grammar tip. We have our blue friend on the corner. The phrasal verbs. Phrasal verbs are very important because they resume the information, they change the meaning, and the phrasal verbs give us a correct way of working and, well, taking the information in an organizing way. Okay, Johan, are you there? Can you listen to me? Let's chat. Yeah. Johan.
Yeah.
Yes. Can you read this chart, please? This slide.
Yes.
Okay,
Phrasal verbs in history taking. Phrasal verbs are often used. Patients and doctors may use them in consultations. A phrasal verb may have several meanings according to context.
Okay. Go
Phrasal
ahead, please.
verb, bring on. Example, is there anything special that brings on the pain? Meaning, cause, when you, example, when you cough, meaning, expectorate, vomit. Carry on, carry on taking the painkiller for another week, meaning, continue. Come on, when does the pain come on? Meaning, commence. Give up. My example, my advice is to give up smoking. Stop. Put on, I put on a lot of weight in the last month or so, meaning gain weight. Turn out, example, she had all the tests and it turned out to be cancer, meaning happened in the end. Phrasal verb, turn up, example, the rash just turned up out of nowhere, meaning appear unexpectedly.
Unexpectedly. Okay, thank you so much, Johan. So you can see, during the context, we get the meaning. During the way we are talking with our patient, we get the meaning. So we have to practice to work with them in order to talk in a correct way and express in a correct way. It's important, very important to use phrasal verbs. And of course, our final phrase of every class, your eye cannot see anything that your brain does not know. We have to consider it's very important, okay, to know what we are talking about. In many workshops, we were talking with you, with my students, and we were talking about the different models of the clinical histories, the American ones, the England ones, and there's a lot of information, and every hospital has its own model, his own structure of doing it. So as an extra material for practicing how to take questions, how to make it, I'm going to send to the group some documents in PDF in order to practice, to check, to review. Okay, just for practicing. In that way, you could see, you could practice and check the difference between hospitals, between the way they work and they consider the information. I found a website when they show us many models, many roles, many ways of asking. And I think it could be interesting for the group, okay? So while finishing the class, I'm going to send it. And well, that's all until this moment. Please fill the pool in order to get assistance.
Teacher, you will share the website too?
Yes, I'm going to share the website and I'm going to share the PDFs, as I was telling you, that I could download because none of them were available at the moment I was preparing the material.
Okay, thank you so much.
It's going to be helpful, I think. It's going to be useful. And well, let's practice with this. Why not if we have the key of doing it? Okay, there's one student that I need to use it. I'm sorry, there is someone. I have one that didn't fill the pool. Oops, I couldn't prepare it. I couldn't correct it if you don't answer it. Everybody can watch the pool. Or maybe there is someone that cannot watch it. We can find another way of solution.
I fill in the pool.
You feel okay. We have 6 from
I
7. You did it to Johan. Catherine, Agar, can you feel the pool? Did you feel it?
I feel it, teacher.
Okay. Ariana, did you feel the pool?
Yes, I feel it.
Yes. Okay, if we don't feel the pool, if someone that is in class don't feel the pool, well, the academical superior turns as an absence. I cannot do anything in that way. So,
That's it, teacher. Sorry, I had a problem filling the pool.
okay. Okay, Fabi, let me share it again, or let's try to do it.
Okay, thank you.
Okay, the rest of the people can go, and well, let me stay with Fabi to correct it. Can you watch it, Fabi?
Yes, I sent it.
Yes, thank you. Okay, so see you tomorrow for the workshop. And if it's correct, perfect. Okay, if you, Fabi, you send it, right?
Yes.
Perfect, so you're free. We finish now on time, yeah. Let me send the material on websites, okay?
Okay. Have a nice night. Goodbye.
Thank you so much, goodbye. Okay, we finished tonight on time. Yes, that's perfect. So